Hi everybody, welcome back to Bread and Butter Primary Care. I'm Dr. Stokes, and I'm back making some videos. It's been a little while, but finishing up on our section on diabetes today. And so today's video is type 1 diabetes treatment. So we're going to talk about how to treat type 1 diabetes. Now the key to treating type 1 diabetes is to remember the pathology of type 1 diabetes. So type 1 diabetes is an autoimmune condition in which a person's immune cells attack the beta cells of the pancreas, usually at an early age, rendering the insulin function of the pancreas non-functional. And so the easiest way to think about type 1 diabetes is these are people who just don't make insulin. And so since they don't have insulin, the treatment is replacement of insulin. That's really all there is to as far as directly treating type 1 diabetes. Type 2 diabetes is a whole other animal, and there's several videos on different medications and different treatment for type 2 diabetes. Type 1 diabetes is insulin management. So we're going to talk a little bit about the different kinds of insulin, when you use which kind, how you decide how much to give a person, the types of things that they should be doing if you're managing patients who have type 1 diabetes. So two general types of insulin, long-acting and short-acting. There's several brands of each one. The most common brands of the long-acting insulin now are Lantus, Levemir, but there's several others. Toujeo, there's some others that are longer acting and things like that. They all have their different properties, and which one of these you'll be using depends on where you're at, what insurance coverage you deal with, and those types of things. But for the purpose of this video, we're just going to talk about long-acting and short-acting. Short-acting insulin are the log insulins, Humalog, Novolog, those types of insulins. And so a person with diabetes, I always like to talk about the two different problems that happen with sugar maintenance in diabetes. One is that your baseline sugar doesn't stay nice and steady. So our livers store glycogen, they drip sugar into the blood all the time. Insulin is constantly there to keep that balanced. When you have diabetes and there's an absence of insulin, oftentimes that sugar drip from the liver makes the sugars rise and rise and rise and rise rather than staying nice and flat. And so a non-diabetic who wakes up with a sugar of 80 and doesn't eat all day will maintain a sugar between 80 and 90 all day long. A person with diabetes may in fact climb, depending on the diabetes type in the person. So that's one problem. The other problem is when we eat, our sugar spikes up, but there's no insulin in a type 1 diabetic to bring it back down. So you have this climbing baseline and you have this surge with food that's not able to come back down. So those two things together are what driving sugar higher and higher in people with type 1 diabetes. And so there's two problems with the sugar, the baseline and the meals, and so there's two insulins. That's the way I think about it. That's why I talk about it with patients. It tends to make sense why we're using two different insulins. So in order to fix the baseline problem, where the sugar's just climbing and climbing and climbing, we use long-acting insulin. So this is insulin that lasts for 24 hours. It's one shot per day. So take like Levemir or Lantus insulin. They give themselves a certain amount of units in the evening time usually, and then they don't have to give that again until the next evening. Okay, so you're replacing that amount of insulin, and you're just carrying out a baseline of insulin that's there. Like I said, that's there to help with the liver input into the blood as well as some of the eating, but mostly that baseline sugar. So that's the long-acting insulin. Short-acting insulin is for the second problem. So when a diabetic eats, their sugar comes up and there's nothing to bring it down. So that's why they take insulin. So the log insulins, Humalog and Novolog, those insulins will bring sugar down rapidly. Regardless if they're high or not. And so you're going to see a drop in sugar if you use those insulins. And so when a person sits down to eat, they have to decide how much insulin to take. Okay? And so usually the dosing of the baseline insulin, the Levemir or the Lantus, the long-acting insulin, that is done just based on the person. And so oftentimes I'll start with 10 units at night, and then you see how their morning sugars come out, and then you can change it. In type 1 diabetics, it's usually a much lower number than in type 2 diabetics. So that is based, there's weight-based dosing of insulin, and so if you have a brand new person, type 1 diabetic, you can use a weight-based dosing calculator to figure out what you should start at. I generally just start kind of at a low dose, and then if it's not high enough, I have them increase it little by little over the next couple weeks until they get there. And we can talk a little bit more about that as well. In fact, you know what? Let's just do that now. So what I'll oftentimes do is take someone, even with type 2 or type 1 diabetes, they're starting insulin for the first time. I'd say, hey, let's start with 10 units at night. So take 10 units, you go to bed, wake up, and check your sugar. If it's higher than 150, then I say stay at the same units for 3 days in a row. So you do 10 units, 10 units, 10 units. Your sugar was never below 150. Go up to 13. And then do 13 and 13 and 13. Sugar was never below 150 in the mornings. Go up to 16. 16, 16, 16. You keep doing that 3 days at each dose, going up by 3 units every 3 days until that morning sugar's coming in around 150. So that's how I tend to titrate and start insulin. Like I said, you can do weight-based dosing and other things like that if you'd like. At the mealtime insulin, so that's that. So you have them on a long-acting, they're taking that, and they have that kind of going throughout, and that's going to help maintain their sugars. But it's not going to help that much with their food. When they eat and their sugar spikes up to 180, the long-acting insulin isn't going to help bring that down very much. They need a short-acting insulin to do that. And so how do they decide how much insulin? How do you know what to tell a person how much? Now, there's 2 ways to do this. The most common way that I've seen people do it is just a sliding scale, where you check your sugar before you eat, you get your number, and depending on that number, you decide how much to give yourself. And so it'll go something like, if it's from 150 to 200, give 1 unit. If it's 200 to 250, give 2 units. If it's 250 to 300, give 3. Or maybe it's 2 and 4 and 6. It kind of depends on the person. So they check it. Depending on how high it is, they give themselves some to bring it back down to where it's supposed to be. The problem with that method, so there's pros and cons. The pros of that method is that it's easy. They only have to think about one thing, and they don't have to do any other calculations. And so if they're brand new, just starting, I sometimes will start with sliding scale only to get them used to taking insulin with each meals. But the problem with sliding based only is it ignores the food that they're eating. And so the most perfect way to dose insulin is for the patient. It takes a lot of patient buy-in and a lot of, they have to have practicing and get good at this, because what they actually do is they have to learn how many carbohydrates are in the food in front of them and give themselves a certain amount of insulin for that food. And so if they're sitting down to eat and they're looking at their meal and they're having chicken and macaroni and cheese, they'll say, well, the chicken doesn't have any carbohydrates, but the macaroni and cheese does. It has this many carbohydrates, and so I'm about to eat 60 grams of carbs. I know that for 60 grams of carbs, I need to give myself this many units to cover the food. They check their sugar. Oh, I'm also 250, so my sliding scale is 6 units. So I'm doing 10 units for the food. I'm doing 6 units for the scale, and so I'm doing 16 units. So they're both correcting for how high they are, and they're giving themselves insulin for the amount of food they're going to eat. Now that takes a lot. It takes a lot of time. Patients have to learn their insulin sensitivity and how sensitive they are to insulin, and so it's one step at a time. So the way I tend to do it when I'm starting mealtime insulin in like a type 1 diabetic is I have them on the long-acting, 1 shot at night, and they're used to that. I start sliding scale, and so all they do is check and they correct for their high, and so they're kind of used to that. And then once that's down, if their sugars are still high, what I'll usually say is, from now on, I want you to take 5 units with each meal plus the scale. And I tell them that you're doing 5 units for the food, or maybe it's 10, maybe it's 15, but you're doing units for the food and you're doing units for the scale. But they don't have to count the amount of carbs they're eating and change that. And then once they're used to that, then they've had some diabetic education, they've met with a nutritionist, and they can start doing where they actually count the amount of carbs, give them insulin for that, check their number, give insulin for that, and then they give themselves their mealtime insulin. So that's just briefly as far as insulin treatment in type 1 diabetics. You need a dose of long-acting for baseline control, a dose of short-acting with meals, which should compose both insulin for the food they're eating as well as how high their sugar is at the time they sit down to eat. I hope that's helpful. This is Dr. Stokes for Bread and Butter Primary Care. Have a great day.